Hello everyone. Good morning. Assalamu alaikum. My name is Abdullah Sohail, and I'm a second year medical student here at FMH College of Medicine. And I have been an intern for CHSR for the past year. And I have also done RCOP level 1. And along with that, I have worked on a few letter to editors and have represented FMH for Research X, which is an organization based in Karachi, which teaches research to medical students throughout Pakistan. Today we bring another journal club from CHSR, and it's related to psychiatry and neurology. So these we're going to discuss a few mental disorders in this session. So let's talk about the study that we're going to be discussing today. The study that is being discussed is the global, regional, and national burden of 12 mental disorders in 204 countries and territories. It is a study that has a span of approximately 30 years from 1990 to 2019. It is a systematic review. Therefore, a systematic review is basically just a type of research where we involve multiple studies relating to one specific topic. We don't include any bias, exclusion criteria of any sort, and we compile those results and create this review. It was done by GBT 2019. This is the global burden of study disease 2019. If we discuss today's panelists, we are joined by Dr. Mohammed Aadil, who is an outpatient psychiatrist at Jacobi Medical Center, New York. He has an interest in addiction psychiatry, which he did from Yale School of Medicine. And we're also joined by Dr. Aitzaz Munir, who is an assistant professor of psychiatry in Rutgers, New Jersey Medical School. And they will be discussing this specific study later on after the presentation. So basically, let's talk about first that what are mental disorders. In a way, थोड़ा बहुत हमें familiar हैं कि क्या होते हैं mental diseases और क्या चीजें होती हैं, उनके parameters क्या होते हैं. लेकिन in a phrase, it is a compromise or misuse of mental health. Compromise in a way that can be genetic or environmental. It could be a misuse. So, for example, अगर किसी किस्म की कोई chemical की intake हुई है या drugs की intake हुई है, that can cause issues with the brain that relates to a mental health disease. So that is, in short, it could be a compromise or a misuse of mental health, and these lead to multiple mental disorders. ये काफी एक staggering figure है, or it's quite worrying actually that if we consider 2019, Pakistan की population around that time was estimated to be around 200 million. और इसकी वजह से हम ये देख सकते हैं कि at least 10%, roughly 10% of the 200 million population, it does suffer from some kind of a mild to moderate or severe mental health condition. And that figure is really quite shocking and alarming because that estimates to be about 20 million of the population. So that is why it is quite critical to study diseases that relate to neurology and psychiatry, especially in a country like Pakistan, where it's very negligent and not approached in a way that it should be. So why did we choose this study? It was published in Lancet Journal of Psychiatry. Lancet is a very high impact factor journal, which is very quite credible if we compare it to JAMA and other such research journals that are present in America. These have high credibility due to high number of citations. Impact factor value just means that the journal specifically has a lot of articles and publications that have been published in a way that they have been cited by a lot of different people and researchers. It has a large sample size due to it being a global study. These include millions of participants. We will look to that later on. It has a large time frame, approximately 30 years. There's a high prevalence of mental disorders in Pakistan, and there's a lot of negligence on the part of psychologists, psychiatrists, and the general public. There's a 95% UI confidence intervals and uncertainty intervals. Basically, these values, 95% UIs and CIs, just indicate the fact that जो भी facts and figures present किए गए हैं इस study में, वो सारे facts and figures, we're 95% sure that these estimates are true and those evidences are factual. 23 different age groups across both genders, male and female, have been studied in this article. If we talk about the article itself, we can see that mental disorders are increasingly recognized as leading cause of disease burden. The Lancet Commission on Global Mental Health and Sustainable Development emphasized mental health as a fundamental human right and essential to the development of all countries. ये दोनों aspects पे देख रहे हैं, social aspects and economic aspects में. The Lancet Commission is basically a commission that is under the Lancet Journal of Psychiatry. So the commission called for more investment in mental health services as part of universal health coverage and better integration of these services into the global response to other health priorities. So the GBD 2019 is a comprehensive international effort because it involves multiple regions and countries. It is the measurement of the burden of 12 different mental disorders. We will look into each of them later. So the GBD uses the disability adjusted life year DALY metric. So what is this metric basically? ये कुछ terminologies हैं, मैं इनको mention करूंगा 2-3 दफा और ताकि अगली वाली slides भी easier हो जाएं. So DALY disability adjusted life year basically इसका मतलब ये है कि अगर कोई पाकिस्तान की जनरल पब्लिक को देख लें, for someone that is healthy, उनकी life expectancy is approximately 60 to 65 years. तो अगर हम consider करें कोई specific mental health disorder, तो हम उसको account में रख के we predict the new life expectancy and we call that disability adjusted life year on the basis of that mental health condition. So अब for example अगर 65 years उसने रहना था, if the person now is estimated to live for 55 years, that is its DLY. So this states here which measures the gap between the current health of the population and a normative standard life expectancies spent in full health 2019 built on previous iterations of the GBD study by incorporating new data and methodological improvements. So basically पहले भी ये study हुई थी in 2013, but it was not on such a large scale. And so because it was not in such a large scale, it was done in 2019 again, and GBD tried to build on those with new data and methodological improvements. So if we consider this map, so this is a global map showing the DALY values and its rates among different countries. We can see that North America and South America are more affected than, for example, Asia, Central Asia, and North towards Asia. The DALY rates are quite high in these countries. And the reason for that is mental health conditions in these countries are not very reported, especially in Central Asia. I believe that this is a limitation because we have the capabilities of conducting such researches at these levels, especially in Asia, where I think the study is not well marketed. But in this map, we can see that that is quite clear, especially in the regions of North America and South America. So if we look at the background, now we're going towards the article itself. The mental disorders included in the global burden of diseases by the GBD were depressive disorders, anxiety disorders, bipolar, schizophrenia, autism, ADHD. Conduct disorder is basically just a small introduction towards conduct disorder. It's your conduct towards other people in any social situation. And this was seen among the age group bracket of 0 to 14, which showed that the conduct of these children, they were more anxious towards how they interacted with other social members, but it did not have a clear correlation with other age groups. The conduct disorder was seen more in the 0 to 14 age group. Eating disorders, idiopathic development, intellectual disability. So the aim was to measure the global, regional, and national prevalence disability adjusted life years. We have discussed the DALYs. Okay, so अब यहाँ पे दो terminologies आ रही हैं, years lived with disability, the YLDs, and years of life lost. So what are these two terminologies? Years lived with disability is just the हमने पहले एक prediction दी थी of life expectancy with a specific mental health disorder. Now we're actually looking at the people that how long did the patients actually live. So that is the years lived with disability. Ab agar 55 years हमने लिए थे life expectancy के, so if the person lives for 30 years, that means that is its YLD value. So the years of life lost would be the expected, उसके जो 55 थे minus 30, and so the years of life lost would be 20. जो उसने रहने थे वो नहीं रह सका, and that's the YLL value. These are important terminologies because we're going to talk about it in the study later. So the methods that were used, they used multiple databases such as PubMed, Embase, and Global. So databases क्या होते हैं? Databases are just libraries or banks that are present on the internet that include a whole bunch of research articles. You can use filters, you can use various Boolean operators to find specific articles that are suited for your search. तो उसमें उन्होंने they obtained data on prevalence, incidence, duration, remission, severity of each disorders. This is the formula. YLDs plus YLLs is equal to DALYs. So the years of years that they actually lived and the years lost would be equal to the effect to the suspected उनकी जो living age hai throughout their period with that mental health condition. So they used a Bayesian meta-regression analysis. ये एक type of meta-analysis ही होती है. Meta-analysis में you combine those specific systematic review articles and you use biases and you use exclusion criteria and inclusion criteria to form a well-versed and a proper coherent study. We used it to estimate prevalence by age, sex, year, and location. Prevalence was multiplied by corresponding disability weights to estimate YLDs. YLDs or YLLs की specific different calculations करने के लिए what the authors did was they used the term disability weights. Disability weights are, they consider the mental health condition, and according to that, from the time of onset, they see के जो the patient's weight, how much has it changed? It could be a decrease in weight or an increase in weight based on that mental health condition, and that factor is known as the disability weight. They used it to estimate the YLDs, and the cause-specific deaths were compiled from mortality surveillance databases. So YLDs, we have estimated disability weights, quantified the amount of the loss associated with each sequela. Sequela is just the mental health condition. So if we look at the methods that were discussed, the death rates were multiplied by the years of life expected to be remaining at death based on a normative life expectancy to estimate YLLs. This is the method they used to actually calculate the YLLs. The YLDs were used for the through the disability weights, but now they're using the normal life expectancy and the death rates to estimate the YLLs. इसमें एक limitation ये थी कि the deaths and YLLs could be calculated only for anorexia nervosa and bulimia nervosa, since these were the only mental disorders identified as underlying cause of death. The other disorders did not correlate to death clearly and definitely. So the 369 diseases and injuries included in GBD 2019 are organized into 4-level cause hierarchy. Causes 4 different levels पे hierarchy create की गई है. Even though they are categorized into one component, they all are different from each other through one specific aspect, and they are collectively exhaustive. So if we talk about the systematic analysis and how they calculated their findings, they used 2 steps basically. First, when they collected all their data, they tested and checked for biases. So कोई भी ऐसी चीज जिसकी वजह से आपकी article और आपकी study authentic ना रहे is a bias. You might not have considered a specific factor in your study, so that you have to eliminate that in some way or the other, where you use different criterias. So for step 1, they used the ones with the biases, and in step 2, they used a gold standard. So gold standard they eliminated those biases and adjusted estimates for model with a meta regression analysis. So step 2 mein unhone meta analysis complete kar liya, and in step 1 they tested the biases. So then they compared these two and they created an adjustment factor. So what was the factor? The factor was the pooled ratio. जो रेशियो थी वो ऐसे उन्होंने डिजाइन की थी कि जो गोल्ड स्टैंडर्ड आर्टिकल्स थे they were considered to be at the numerator, and the denominator was the one that was the alternate estimates, यानी कि जिनमें bias included थी. तो अब जब हम बायस को इंक्लूड कर रहे हैं और ऊपर वाले में बायस को नहीं इंक्लूड किया और उसमें उससे एक्सक्लूजन क्राइटेरिया की वजह से रिमूव कर दिया था, तो वी कैन एक्चुअली सी दैट इफ द रेशियो इज हायर, then therefore the analysis is correct and the articles are more and more authentic. So the compiled studies reported both the gold standard estimate and the alternate estimate and calculated the ratios within these studies. Just discussed, they also looked for points of gold standard and alternate estimates between studies, matched by age, sex, location, and year, and calculated the ratio between these estimates. Severity proportions were calculated to reflect the varying levels of disability associated with a specific disorder. So the severity proportions, even though it was very difficult to conduct due to the high amount of sample size that was present, उन्होंने फिर भी specific groups of ethnicities को use करके severity बना ली कि this disease is mild, moderate, or severe in its presentation of its symptoms. If you look at the comorbid, so yes, this was a limitation because whenever you do a study on a certain disease, you can see that there's always a comorbidity. So what is a comorbidity? A comorbidity एक ऐसी चीज है कि अगर for example आपकी एक disease हो रही है, it can cause some underlying other presentations. So for example, diabetes can also be co-occur with the hypertension. It can also co-occur with polyuria and, for example, obesity. So these are all comorbidities that had to be adjusted when we are studying diabetes. So isme bhi, when we study one specific mental health disorder, we have to remove the other comorbidities. The co-occurrence of different disease injuries were estimated by simulating populations of 40,000 individuals by location, age, sex, and year. Simulated individuals where each population were exposed to the independent probability of having any combination of sequelae. So the point यहाँ पे जो है, it is the important point is the comorbidity correction estimate the difference between the average disability weight of the individuals experiencing one sequela and the multiple combined disability of those experiencing multiple. So multiple conditions को भी उन्होंने mind में रखा और उसकी वजह से उन्होंने जो combined disability weight variations आ रही थी उसके भी adjustments उन्होंने किए थे इस study में. So what were the results? The results were quite shocking in a way that they accounted for 654 million estimated cases in 1990 and 970 million in 2019. Yani कि 48% was increased the mental health conditions and the number of people that were affected with mental health in the 30 years of study. No marked increase were identified in the age standardized prevalence of any mental disorder between 1990 and 2019. Yani कि जो specific age groups there, the rate at which the mental health condition was affecting each of them did not really change in the 30 years. So इसमें जो interesting चीज़ है देखने वाली कि mental disorders, anxiety disorders ranked on top out of all the 12 mental disorders that were present. And we can see one thing that is quite clear from this graph and its correlation is that females were affected way more in 1990 as well and 2019 in both mental disorders, anxiety disorders, as well as depressive disorders. So अगर हम इसी को ही ले लें कि male में 317 and female में 337 million, these are million. So 2019 were 462 and female were 507 million. Anxiety disorders may it's a drastic difference, more than 90%. 73 million in comparison to 121 million in 1990 and 113 million to 187. So only in other mental disorders, अब यहाँ पे other mental disorders में basically सारे eating disorders or schizophrenia, ADHD आ जाता है. Only in these specific statistics उन्होंने mention किया है कि males में statistics के prevalence थोड़ी ज़्यादा थी, but जो common और सबसे clear थे, which were depressive, anxiety disorders, they had way more influence on the female population in both studies, 1990 and 2019. The age standardized DIY rate for mental disorders were 1,426 per 100,000 among males and 1,700 per 100,000 among females. वही females में ज़्यादा. So depressive disorders account for the largest proportion of mental disorders. Depressive disorders are number one in 2019, followed by anxiety disorders and then schizophrenia. So 37%, 22%, 12%. एंड इसमें जो दूसरा इन्होंने बताया हुआ है इसी में, which I wanted to mention specifically, is that the peak of these mental disorders was seen in middle age, specifically between 25 to 35 years of ages, and decreased steadily with age. And it also had a correlation which showed that it did not peak previously, but before the ages of 25 to 34. I actually have a diagram which I show, which I placed here. So 30 to 34 age bracket जो है उसमें they have shown that conduct disorder, intellectual idiopathic developmental intellectual disabilities, eating disorders, bipolar disorders, all of these, especially depression and anxiety, had the highest impact on this specific age group. The other age groups did not have this much of a drastic difference. And we can see that anxiety and depression, the links between them are quite. The only difference जो यहाँ पे noteworthy है वो ये है कि 0 to 14 का जो age group है उसमें this study का result ने show किया था जो conduct disorder है वो इनमें ज़्यादा आ रहा था in comparison to, for example, let's say depression and anxiety. This was the effect. So the mental disorder is the second leading cause of wild disease worldwide in 1990. And the depressive disorders, with mental disorders, depressive disorders is the highest in all age groups except the 0 to 14-year age group category. जो बिल्कुल adolescents, neonates होते हैं, उनकी category में conduct disorder was the leading cause of burden. So कुछ limitations थी, critiques थे इस article में जो कि discuss, which should be discussed. Acknowledgements यही थी कि Belinda Gates and the Gates Federation funded this research. Various institutions helped to fund this research as well. But the limitations were that the estimation of severely distributed use करके they created this study. So this limitation at a level here. Assume
I think Abdullah, you're cutting out right now.
was there a network issue? Can I continue? Okay, so I'll go over the limitations again. The estimation of severity distributions was derived from few studies, mostly from high-income countries. जो कुछ countries जो Scandinavian, European वगैरह हैं, उन्होंने उनका sample size लेके study की थी, not using Asian and other ethnicities. The study assumes independent distributions. Dependent distributions नहीं थी. Comorbidities को उन्होंने नहीं consider किया say properly. The disability weights were derived from brief descriptions of disease that might not capture the full complexity of symptoms. Obviously, इसको अगर हम consider करें तो जो disability weights होते हैं, when your weight varies, when it increases or decreases, it could be multiple factors. बहुत factors हो सकते हैं, not just one specific mental health condition. So they did not account for that. The study did not consider any substance use, कोई chemical use, drug का use, ऐसी abuse को नहीं उन्होंने consider किया in their study. और if we look at the highlights and conclusions of this entire findings, we see that the findings of GBD 2019 emphasize the large proportion of the global disease burden attributable to mental disorders and the global disparities in that burden. There was no evidence of global reduction in the burden since 1990, despite evidence-based interventions that can reduce the burden across age, sex, and gender. यानी कि बहुत ज़्यादा interventions के तरीके थे since 1990. Because इतनी ज़्यादा advancements medicine में हो रही हैं, लेकिन फिर भी there was no action being done on this. So this study was required. This is the largest study of the sort since 2013, which was conducted in 2019. 2013 में पहली ऐसे एक study हुई थी, but उससे अलावा भी it was not on this large of a scale. A coordinated response by governments and the global health communities urgently needed to address the present and future mental health treatment gap. So that's all for the presentation. This is open for discussion. So I will request Dr. Aadil and Dr. Aitzaz to please discuss this.
Aitzaz, do you want to go first, or should I?
You can go first, and I can discuss like further.
Thank you. Thank you so much, Abdullah. I think keeping in view how much complex the paper was, you did a fantastic job in simplifying and explaining it to everyone. Or I really like that you kind of categorized into different segments to make it more simple. So really good job. There are a lot of things that I want to cover in this paper because I think it kind of gave us a really good overview about the burden of mental health disorders in the community and the impact of those disorders in terms of disability or the years of life lost. But I think that when we're doing a journal club, there are 2 or 3 things that every time you're reading a paper, you should focus on. And one of them is who are the authors and what is their kind of, there's an objective in the paper they're trying to look into, but there's also an ulterior motive that they're trying to achieve something. And it can be in the form of pharmaceutical company giving them funds to promote certain medication, or it can be an NGO conducting certain studies to implement certain policies. So those are the things that whenever you're reading an article, you should also look into. In this case, as you can see, this is Bill and Melinda Gates Foundation was funding this paper. And their main aim is to just highlight the burden of mental health issues in the community, and so that we can have more focused or targeted interventions in those areas. The other thing I would say to focus in when you're reading a paper is the evidence they're trying to build their claim on. And in this article, it's kind of based on previous epidemiological studies. And there's a huge discrepancy. Like, there's not a lot of data coming from Asia, and there's a lot of data coming from certain Western countries. So if you put all of them together, it doesn't give a really good picture. So it can be confusing. And I'm going to talk more about that later on. But first, I want to talk about the, you mentioned about how to diagnose or what mental illnesses are. And I think that's a good segue to jump in into the core of this paper. So if you look into the DSM, which is like the main diagnostic book or the main Bible that is being used to identify mental health disorders in the community, there's a lot of issues there. And the reason is that it is very symptom focused, and it goes into the history of how DSM was created. And there's no intersectionality, like there's no focus on the cultural, religious, and socioeconomic aspects. And you just have to find out which symptoms are present or not present, and then you just diagnose a person with XYZ disorder. So for example, for PTSD, there's no aspect that covers religion, spiritual, or moral injury, which plays a huge role in the development of PTSD. So if you have like mood reactivity, if you have depression, if you have anxiety, if you have nightmares, you can meet the criteria, and those all symptoms can be an outcome of other socioeconomic factors or other trauma-related factors. So this is one of the biggest limitation I feel in this study, is that it just uses the same DSM labels and just and just use it everywhere across the globe without considering intersectional problems in the implementation of those disorders. PTSD for a veteran in Pakistan, PTSD for a veteran in America is going to be entirely different ballgame. So I think this is the biggest issue. I don't think that it gives a really good picture for a lot of reasons. And then you also mentioned about the disability burden. Now that's another issue that I have with the study is it's like theoretically speaking, if you want to quantify it, yes, I understand from a perspective of a researcher, it is so much easier if I use the same same algorithm that I'm using for America, and I apply that to an Asian country as well. But the disability burden for someone living in say in Pakistan is very different. So if a woman has schizophrenia in Pakistan, her disability is going to be drastically different compared to someone in Western countries who have like disability insurance, who will get some welfare checks, who has nursing care, who has hospitals available for immediate care. Like if someone in Pakistan has schizophrenia, it impacts the entire family. It is a huge financial cost every year. Let's not forget all the emergency visits. Let's not forget all the stigma that she has to face every day in the community. So I think it just kind of simplifies the disability cost and the mortality cost just for the sake of research. And that's what happened when you are doing cross-sectional studies. They are very cheap to conduct. They're very easy to implement. You just use a survey, you ask a lot of people, and you just run it on the algorithm. They are good just to give you an idea where you need more resources, but it just misses a lot of targets if you want to dig deeper into the whole concept and the cost of the mental health issues. What do you think, Aitzaz?
Right. Thank you again, Abdullah, for such a wonderful presentation about this complex article. As Dr. Aadil is saying, yes, there are a lot of questions that arise in this paper, specifically in relation to the disease burdens and disabilities and the diagnosis of the diseases, disorders, specifically in Western countries versus Asian countries. And there are a lot of countries that are not even included in the studies, that they don't even have properly conducted surveys, and we don't know what disease burden is there, what is a lot of underreporting, especially in Pakistan, for example, countries like Pakistan, India. There are a lot of stigma that results in very much underreporting of these diseases, these disorders, and people doesn't show up to the clinicians or doctors that mainly result in like catching this population. A lot of quacks out there that's also like causing multiple issues, further complexing the situation with already stigmatized population, with a lot of disabilities already, and getting no help, zero to like very little help in terms of psychiatric care, especially the like schizophrenia and depression. And a lot of our educated population as well, they are like also very stigmatized, and they don't show up to the mental health clinician just because of stigma. Like, why should I go to a psychiatrist and see the psychiatrist? And in these surveys, even if they are conducted, there's a lot of these surveys people like underreport, and these are like very specific population usually is targeted, and it's not like globally assessed data that is done, like for example underserved communities or areas in Pakistan that are not even included in this kind of study. Similarly happens in the other Asian countries. However, it's different here in United States or other developed countries. So yes, that's one thing. Again, we need to focus more on like this is like very broad data that doesn't have a very specific knowledge base that we want to get out of. It's just like giving numbers and facts and figures about disease burden in Western countries, but there's no hard and fast data that we can use to see what's going on in our country, in Pakistan, and we don't have anything to rely on. So that's what my take is on this paper.
Actually, the limitation here is quite drastic, because they did mention that they specifically used high-income countries and they could not use their research to go deeper into the specific countries that were more involved in, for example, Asia and other countries that were third class towards third world countries. And so I actually did say that there is some sort of an exaggeration in that specific world map that they showed, where they emphasized that most of the north part of Central Asia, they had the least amount of mental health disorders that were reported, as well as in Pakistan, they've categorized us to the lower ones that don't show a high prevalence rate. So that is quite alarming, because I feel that not a lot of research and not a lot of proper field research is being done here, and especially in Asia, for example. So that is a very big limitation indeed.
The other thing I find interesting, which is like which collaborates with other research as well, not new. The highest mortality rates are in the eating disorder. Anyone has any idea why that is? Why does eating disorder continues to have like much higher mortality rates? Anorexia nervosa, bulimia. Put it well, societal pressures. So for eating disorders, the thing is that, you know, not only there's like a person with the eating disorder is most likely to be malnourished. Yeah. So malnourishment along with electrolyte imbalance and the compulsive nature of, you know, really plays an important role, and it is comorbid with severe depression. So people who have eating disorder most of the time have major depressive disorder, and most common cause of death is suicide. That leads to a very earlier death, and obviously the medical malnourishment and medical complications are also playing a role. And on top of that, even like in USA, it's really difficult to find a specialized eating disorder clinic, because most of these patients, they cannot be admitted to a general psychiatry unit because they have all the medical ailments. So there has to be like a specialized unit where they can get NG2 feeds, IV fluids. Those things are not allowed in a psych unit. So because of that, because that becomes a major limitation in proper care. And then the other thing that I saw that there was a focus on the prevalence rate among males and females, which is again, I won't say it's anything new there. Mood disorders are much more common in females, like anxiety disorders and depressive disorders. And it also has something to do with the cultural aspect of it. Like females are much more willing to come for help and willing to report those disorders compared to men. And if you look into the psychotic disorders like schizophrenia or even bipolar disorders, the prevalence rates are almost the same, which this study also, you know, collaborates.
One thing I wanted to add in the study, you mentioned about conduct disorder, 0 to 14. Conduct disorder is diagnosed before age of 14. It cannot be diagnosed after age of 14. After age of 14 is antisocial. But that's why it's little, like you said, it's more you can see in 14, but it's not, it doesn't look what it is. It's diagnosed before age of 14, and it has to be diagnosed before age of 14 in order to be diagnosed as antisocial as an adult. The patient has to have a conduct disorder to be diagnosed as antisocial when he's an adult. There's no mention of like antisocial disorder in the whole paper, just conduct disorder and nothing else there. And highlighting it like in a big picture, and there's no other childhood disorder that are there, specifically ADHD or like DMDD or ADD or ODD. They're like a lot of the childhood disorder. They are not even like those. Like they are mentioning conduct disorder, they should have been mentioning or other disorders that also be like are more prevalent, like especially ADHD is very prevalent among the children. That is not like mentioned in this paper. One other thing I was looking at was like for schizophrenia patient, they like about the weight gain. Is one of the reason, one of the things that happens is a complication of schizophrenia, but it's more about the dyslipidemia rather than the weight gain. So dyslipidemia is a bigger problem in patients with schizophrenia, and they are more likely to die of cardiac diseases or other medical illnesses rather than anything else. So like if you compare with the normal population, schizophrenia have more likely to have lipid profile disarrangement and cardiac diseases, and they end up dying because there's one of the most common cause of death in schizophrenic patients, just like cardiac illness or MI.
Yeah, so if you're schizophrenic, you're already predisposed to having cardiovascular issues, and all the antipsychotic medication, both typical and atypical, they also have impact on the lipid profile. So your chances of having cardiovascular issues are like twofold now. So all of those individuals, most of the time they die either by suicide or by severe cardiovascular problems.
So it is quite.
Sorry, I couldn't hear you. You cut down.
Cannot hear you clearly.
Sorry.
Okay, so hi everyone, this is Iman. I'm one of the core team members at CHSR. I think Abdullah is having internet issues, and if anyone has anything else to add, we can do that right now. And if anyone has any questions, please feel free to drop them in the chat box.
Yeah, and in the meanwhile, I will just add one more thing that one criticism on these sort of studies is that let's say they find out that XYZ community has a decrease in mental health services, or they found out that XYZ city has increase in ADHD in terms of the prevalence. So what happens next is that they relocate more resources there, and there are more psychiatrists and nurse practitioners in that community, and they are under the presumption that more people here have ADHD, and then they will be prescribing more, they will be diagnosing more under the false pretense, under the false bias. And keeping in view that because we don't, the criteria list is not that stringent in order to diagnose certain mental health disorders, it will lead to more diagnosis and ultimately cause more structural injury or medical injury because of overprescribing. And the prevalence rate may go further high and more resources will be allocated. And so it becomes kind of a vicious cycle. So I think one aspect that hopefully we can focus on is how can we improve the diagnostic criteria or the scales which are more valid and reliable, so that we don't indirectly cause those structural injuries or medical injuries. But if anyone has any questions, please feel free. And thank you, Abdullah,
Okay.
for the great presentation.
Please use the chat box. Yeah, please use the chat box if you want to, if you have any questions related to this topic. I actually have a very bad internet connection right now, but I wanted to mention that it is quite uh, a big fault in the article that they actually use these specific lines that the conduct disorder is highly prevalent in the age group of 0 to 14, which is actually, as Dr. Aitzaz said, that it is diagnosed between the 0 to 14 category. So they had to add an additional factor or in fact in their study to make it more prolonged, as they may say, but it actually made it a bit less authentic than it should have been. So does anyone have any questions regarding anything so far? So I think that should do it. Okay, so I think that's it for the entire study that we discussed. We talked about the limitations, and as Dr. Aitzaz and Dr. Aadil both pointed out, that there were some flaws in the article as well, and they talked about specific relations of, for example, schizophrenia and dyslipidemia, and they talked about the other aspects of the article that had to be talked about but could not be talked about because of the sample size being very specified. Okay, so we have a question. So are there any recommendations on how we can improve data collection in the global south?
Yes, and I think someone also sent me, Muhammad Saad sent a message. What specific steps or strategies do you believe should be taken to initiate meaningful changes in the DSM, ensuring it becomes more adaptable culturally, and more adaptable and culturally sensitive? Okay, so for the DSM, what happens basically is, just to give you a background, DSM was created after the World War II, and they saw veterans who have PTSD, and they just started to point out the symptoms they were seeing in every veteran, and then they classified different categories like depression, anxiety, OCD, and over the course of the years, they kind of improved on that, removed certain symptoms, tried to make the criteria more stringent, but still a bit vague. And it's still a bit, I would say, conceptually very generalized. What they're trying to do right now is that they have made like specific committees on each disorder, and their goal is that to implement the cultural and religious aspect and some socioeconomic aspects into it as well. So for PTSD, I know that the committee is focusing on the aspect of moral injury. Like, how does your moral values get impacted because of the trauma, leading to more guilt and shame? It's going to be a bit difficult to implement it implement it in a clinical setting, but I think that's the route they're trying to take right now, which is a good step, because without that, I think we will be missing the mark completely. So it's going to be a slow process, because what we have right now in terms of the DSM criteria is not bad. It's really helpful to target the medication in that direction. But if we can make it more intersectional, I think that would be a really good idea. And then there are certain physicians, like I know some physicians in Pakistan who are making scales in Urdu, and they will add the cultural and religious aspects in those scales. So for depression scale, like they use Hamdi and Becker scales, and they added the aspects of religion and culture into it. Like, does your religious values help you to live, or does your religious values lead to more guilt or shame? And I think it's really helpful to give the perspective. It's gonna be a long journey to improve those criteria and their skills, but I think we are headed in the right direction overall.
Yes, as Adil said, DSM has like a lot of limitations because it's mainly focused on the like obvious symptoms that are not involving the cultural and social economic aspects into it. There's another, like we can say in Pakistan, like we don't have anything like that developed by us. There's no research, there's no scale. They are developing, it's a good thing, we right direction, but there's need to be more research and more uh, work on it needs to be done, especially to remove the stigma there, and there like more awareness. There's like very less efforts for awareness. For example, there's no suicide helpline. There's no like easy access to. We don't even have many inpatient psychiatric unit and even the long-term units. There are like only a few, and people are mistreated there, and there's no proper treatment that is being practiced. In terms of substance abuse, we just ridicule these patients and we don't even look at them. They are homeless. We don't want to take care of them because they're smelly, they look bad, and we don't want to help them at all because they use drugs. That's a sin or whatever we think about. But thinking about them and helping them is like very big step that we need to do, but there's nothing I would say like this being done, and there's a whole big like gap is there that we can actually step forward and start doing something about it, and we'll have more awareness and more focus towards these issues so that we can help patients as a whole and help them in a better way.
Okay, I think that
Yeah, and
clears
to
it.
answer An's question, how can we improve data collection? I think it's all about the money at the end. All the studies, most of the studies that are done, it's all either about finding resources, allocating resources, or pharmaceutical companies trying to find out how they can market medications. And I just don't see that happening in Pakistan right now. Most of these studies are done, like this study is like an NGO. So it's going to be difficult, and I think we would be missing a lot of crucial data without that.
Yeah, so I think that clears it up for the DSM and the diagnostic criteria, especially in reference to people in Pakistan. Does anyone have any other questions regarding this study?
Or any question regarding psychiatry, we can answer.
Yeah, anything regarding psychiatry or anything that you want to ask the panelists? Okay, so I think that's it for the session. So thank you so much, Dr. Aadil and Dr. Aitzaz for joining today for this journal club. And thank you for all the participants that have been looking at and understanding what has been prevailing in this entire study and talking about the entire global burden of disease regarding the 12 mental disorders. So, so we do have a question: how different is psychiatry in USA and Pakistan?
So there's a lot of differences based starting from like diagnosis and treatment options. It's a big, very broad question. I'm not able to answer it like in very short.
I think if Iman, if you can ask the question more precisely, this is quite vague. This is very broad.
No, I think I can answer this
Okay,
one. I
okay,
think it's a
okay,
really good
sure.
question. It's like it's like extremely different. And I worked in um, um, I worked in FMH with a psychiatrist there, and I also worked in the Aitzaz clinic, the addiction rehab clinic. We have. It's different both in terms of the medication management and in terms of the psychotherapy that we provide. We have a lot more options in terms of the medication, and the psychotherapy techniques that are being taught here, and the way we use them were entirely different. And we are giving, we have ample time, like we are giving at least half hour with each patient when we are seeing them for follow-up, and at least 1 hour if it's a new patient. So if we can do medication management, and we can also do, cognitive behavioral therapy or supportive therapy, whatever sort of therapy you're in. And I feel that in Pakistan, we were not doing evidence-based practices. Like we were prescribing on medication to a lot of problems. And then I never saw anyone doing therapy. So I after working there, when I came here and I did rotations in America, I think it was like an eye-opening experience. So for those of you who are interested in psychiatry, like actual psychiatry, once you go to any foreign country, try to do some rotations with a mentor or someone, and it will give you kind of an idea what actual psychiatry is. And I feel that many times people who just, work with psychiatrists in Pakistan, sometimes they don't know, or they miss the point of how they can help the patient properly. Yeah, that's all I have to say.
Next question regarding elective. There are multiple options you can do. First thing, always like take a step, like step 1 and step 2, if you really like want to increase your chances for the electives. But there are like multiple options you can apply through. There are multiple hospitals that offer electives. There's Mayo Clinic, there is St. Elizabeth Hospital in DC. There is like Brookdale Hospital. There's like a lot of options that where you can apply for an elective. But it has to be before your final year you apply, so that you can do an elective after your final year. Come here, take visa, do an exam, and just however you want to plan it out. But that's the good timeline when you apply for an elective, and you can get an elective as a medical student. After a medical student, you cannot do elective anymore. It's called externship, and they are really, really hard to get. Elective is a relatively easy to get compared to after graduation. When you finish your studies, people are it's like really hard to get an externship anywhere in US, but it's not possible. You can do the exam, reach out to the programs, and you might have an opportunity to work with them. But elective is usually with the medical school, like the big hospital, university hospital, you will get really good letters. You will be able to have invaluable experience at a teaching hospital as a big university hospital. While externship is usually done in a private clinic with the physicians or some small community hospitals, they won't give you the full aspect of what you are trying to get. So being a medical student, this is the right time if you really want to pursue career in the US, do elective, apply for elective for the field you are interested in, and it will give you a tremendous head start compared to other people who are applying for the same field in the United States for residency. But first, most important part is this USMLD.
I would say that I didn't do an elective because I was concerned about the cost of, the entire trip and the cost of the elective in itself. My advice would be that if you're trying to be cost effective, try to find someone in USA or in UK, wherever you plan to go, and start working with them on some research project. And let's say you are working with them on a project for like 1 year. When you are applying, you can put that as an experience as well. And hopefully by then you will have 1 or 2 publications with them as well. So if someone is in an Ivy League program and you're working with them, that's a pretty huge deal. So I did that. I didn't do an elective. Also keep in mind that, as Aitzaz mentioned, finding observerships or externships is hard, but it's way more difficult, especially in psychiatry, because most of the inpatient units are locked unit. So you need a hospital approval to get in. So it's plan a way ahead in time if you plan to do psychiatry externships or observerships. The clearance process sometimes take months.
Okay, so that was for the electives and other experiences that we need for psychiatry matching. But I would advise everyone that if they do have any more questions, they can comment on it. But we have asked in the comment section from both of the panelists that if they are okay with sharing their email address, and Dr. Adil has shared his email. So if you have any queries, you can email him at his account, at his Gmail account, and if Dr. Aitzaz is also fine, he can comment his. So both of them have basically commented their email addresses, and you can mention any queries that you have with them. And I would thank both of the panelists today that they took their time out and uh, entered the journal session and talked about this study. And we'll wind up now. So thank you everyone for joining. I would request Iman to take over if she could. Okay, I think that's it for this session. Thank you everyone. We're ending now. Thank you so much.
Thank you for inviting us. Bye-bye.
Thank you.
Thank you.